6, Module 6. Apply the nursing process to the care of the child with food and fluid needs. Here are the subcompetencies for this module. The reading is from the following pages of your Ricky textbook, Chapter 42. Fluid and electrolyte balance in the infant is assessed primarily through physical signs because dehydration can occur quickly. A normal infant should have urine output of at least 1 milliliter per kilogram per hour, which is why intake and output is important, and anything less is an early sign of dehydration. Mucous membrane should be moist. Dry lips or tongue are early warning signs. The interior fontanelle should be flat, while a sunken fontanelle is a classic sign of dehydration and a priority assessment in infants. The urine specific gravity normally ranges from 1.002 to 1.03 according to the National Library of Medicine. As dehydration occurs, the urine becomes more concentrated and this number rises. Stools should follow the infant's normal pattern, and changes in frequency or amount may be an early clue to fluid imbalance. A well-hydrated infant is alert and age-appropriate in activity, while lethargy is a later and more serious sign. Skin turgor should be elastic with slow return indicating fluid loss. The presence of tears when crying is an important hydration sign, while the absence of tears could indicate dehydration. Fluid requirements in infancy are determined mainly by body size or weight and their current hydration status, which is why pediatric fluid calculations are weight-based. One of the best indicators of fluid volume status is a daily weight taken on the same scale because even small weight changes in an infant can represent significant fluid loss. Because infants can't concentrate urine well and have a higher metabolic rate, they are at greater risk for dehydration, making these assessments critical. Dehydration occurs much more easily in infants than in older children or adults. This is mainly due to increased insensible fluid loss from fever, a higher percentage of extracellular fluid, and several developmental differences in the GI and GU systems. Insensible fluid loss means the water lost from the body that you can't see or measure or easily notice. So this can occur through evaporation through the skin or through the lungs during breathing. So infants have a higher basal metabolic rate and a larger body surface area relative to their size. This means they lose more fluid through the skin and respiration even when they're healthy. So this loss increases significantly during fever or illness. One major reason infants are at risk is what we call the GU factor, signifying renal immaturity. So an infant may have several wet diapers each day even if fluid intake is inadequate. This happens because the kidneys are immature and can't concentrate urine effectively. So the infant continues to produce urine even when the body is trying to conserve fluid, which can lead to a misunderstanding into caregivers thinking the hydration is adequate when it's not. Infants also have anatomical differences in the GI system, so their gastrointestinal tract is immature and does not fully mature until around age 2. Faster peristalsis and illness such as vomiting or diarrhea can quickly lead to significant fluid loss. Another key concept is fluid proportions. Infants and young children, as we mentioned, have a much larger proportion of body water compared to adults. Until about age 2, the extracellular fluid makes up about half of their total body water. Because extracellular fluid is lost first during hydration, infants can become dehydrated very quickly. So all of these factors together place infants at high risk for fluid loss. Again, that's their higher metabolic rate, larger body surface area, immature GI tract, and faster peristalsis, immature kidneys, or the GU factor that cannot concentrate urine, in addition to an immature immune system and high extracellular fluid percentage. So this is why dehydration can occur rapidly and why careful assessment is very critical. This chart taken from your textbook shows how dehydration presents in infants and how the findings progress from mild to severe. The earliest signs we usually notice are dry mucous membranes, changes in the urine output, and absence of tears. These are the first visible clues that fluid balance is changing, so the caregiver can actually be educated regarding this and to look out for it. As dehydration worsens, we begin to see changes in mental status. A mildly dehydrated infant is alert. With moderate dehydration, the infant may become listless. In severe dehydration, the infant may become lethargic or even comatose. This neurologic change is a serious red flag. Fontanelles in eyes are very important. In mild dehydration, fontanelles are soft and flat, and the eyes appear normal. With moderate dehydration, the fontanelle becomes sunken, and the eyes begin to appear sunken in the orbits. The sunken appearance becomes very pronounced in severe dehydration. Oral mucosa changes from pink and moist to pale and dry in moderate dehydration, and then very dry in severe dehydration. Skin turgor is another key assessment. In mild dehydration, the skin is elastic. In moderate dehydration, the skin returns slowly. We see tensing in severe dehydration, where the skin remains elevated after being pinched. So cardiovascular changes also occur. Heart rate may increase in moderate dehydration as the body tries to compensate, but in severe dehydration, this can progress to bradycardia, which is very late and also a dangerous sign. Blood pressure may remain normal for a while, but eventually drops in severe dehydration, leading to hypotension. Perfusion to the extremities will also change. So in mild dehydration, we have the hands and feet appearing warm, appearing pink and feeling warm with brisk capillary refill. It'll be delayed in moderate dehydration, where in severe dehydration, the extremities will become cool, mottled, or dusky with significantly delayed capillary refill. So urine output follows this pattern also. There will be a slight decrease in mild dehydration, dropping below the 1 milliliter per kilogram per hour in moderate dehydration and becoming significantly less than that in severe dehydration. So the key takeaway is that severe dehydration affects neurologic status, cardiovascular stability, skin integrity, and urine output. When you see lethargy, bradycardia, hypotension, tensing of the skin, sunken fontanelles, and very low urine output, this is an absolute medical emergency in an infant. Hydration in infants and children is classified based on the relationship between water loss and electrolyte loss. In isotonic dehydration, water loss equals electrolyte loss. This is the most common type of dehydration seen in children, especially with vomiting and diarrhea. Because both are lost equally, sodium levels often remain within the normal range, which can make this type harder to recognize based on labs alone. We rely heavily here on physical assessment. In hypotonic dehydration, water loss is less than electrolyte loss. This means the child is losing more sodium than water. So as sodium levels drop, fluid shifts into the cells, which can lead to swelling and increases the risk for complications such as cerebral edema. In hypertonic dehydration, water loss is greater than electrolyte loss. This is often seen with fever, poor fluid intake, or excessive insensible losses. As water is lost, sodium levels rise, Fluid shifts out of the cells into the bloodstream, causing cellular dehydration. This type can be especially dangerous because neurological symptoms may appear due to brain cell dehydration. So remember, isotonic dehydration, the most common in children, is different from hypotonic and hypertonic. These are important to recognize the lab changes as well as the potential complications and how to treat each type of dehydration. Sometimes you'll hear the term for hypertonic dehydration, for example. This is when there's a greater loss of water than electrolytes. Another way that it may be mentioned is hypertonic dehydration is when water loss is in excess of electrolyte loss. So that's another way they kind of mention that. Let's review the common causes of vomiting and diarrhea in infants and how we think through them clinically. Vomiting can be acute, chronic, or cyclic. Acute vomiting is often related to gastroenteritis and infection. Chronic vomiting is commonly seen with conditions like GERD, which is gastroesophageal reflux disease. Cyclic vomiting is repeated, predictable episodes of intense vomiting with periods of complete normal health in between. So in assessing for vomiting, it's important to look at the onset and the character because this may help us determine the cause. So diarrhea can also be acute or chronic. Acute infectious diarrhea is often viral. The rotavirus is the most common type. It can also be bacterial, such as Salmonella or E. coli, or it can be parasitic. Chronic diarrhea is more concerning because it's difficult to stop or treat, such as intolerances with milk or soy protein. Another cause in infants is Hirschsprung disease. So this is a congenital disorder where part of the large intestine has no nerve cells. So nerve cells help the bowel relax, and because this no longer functions, the affected segment of the bowel stays tightly contracted, whereas normal bowel may become distended because stool and gas can't pass easily. So infants may have chronic constipation, chronic diarrhea, abdominal distension, or periods of delayed passage of meconium when they're young at birth. So understanding whether the vomiting or the diarrhea is acute, chronic, cyclic, infectious, or related to a structural problem can help us predict the risk for dehydration, and it can guide our assessment and treatment for the infant. The most common causes of diarrhea are vomiting and diarrhea. So these both lead to direct and rapid fluid loss and are the primary reasons infants become dehydrated during illness. When we think about diarrhea specifically, we know that rotavirus is the leading cause of acute diarrhea in infants and young children. This is important because rotavirus can cause significant fluid loss very quickly. Prevention is key. So we know the rotavirus vaccine is essential because it protects infants from the most common cause of pediatric gastroenteritis and significantly reduces the risk of severe dehydration and hospitalization. Decreased oral intake, decreased PO, in other words, is another major contributor. Infants who aren't feeding well, perhaps due to illness, fatigue, or discomfort, can quickly develop fluid deficits because they rely entirely on others for hydration. Fever also plays a large role. Fever increases insensible fluid loss through the skin and lungs, meaning the infant is losing water even if there is no visible perfusion. Diabetes can lead to dehydration because excess glucose in the blood pulls water out through the urine, causing increased urination and fluid loss. Burns are another serious cause because damaged skin allows large amounts of fluid to escape from the body. Focus on the laboratory and diagnostic tests that help us confirm dehydration and determine its cause in infants. Electrolytes are very important because they help us determine the type and extent of dehydration. Changes in sodium levels, in particular, can help us identify whether the dehydration is isotonic, hypotonic, or hypertonic. The BUN and creatinine levels, as we know, helps us assess the severity of dehydration. When these values are elevated, it often indicates that the body is conserving water and kidney perfusion is decreased. This happens in more significant dehydration. When diarrhea is present, stool testing becomes important. A stool culture is used to identify bacterial pathogens and confirm the diagnosis if a bacterial cause is suspected. A stool ova and parasite test, or we can call it the stool O&P, is used when a parasitic infection is suspected. Stool pH and reducing substances help us identify carbohydrate intolerance, though this is useful in infants with chronic diarrhea, where milk or formula intolerance may be contributing to ongoing symptoms. So together, these labs can determine not only how dehydrated the infant is, but also why the dehydration is occurring. Now let's talk about how we can manage dehydration in infants and the medications that may be used. The most appropriate initial treatment for mild to moderate dehydration is oral rehydration therapy, or ORT. So solutions like Pedialyte contain sodium chloride and potassium, which helps replace both the fluids and electrolytes safely. The American Academy of Pediatrics, World Health Organization, and the CDC all agree this is the most appropriate management of dehydration. If dehydration is severe, IV therapy may be required, especially if the infant cannot tolerate PO. So the typical fluids used are normal saline or lactated ringers because they help rapidly restore the circulating volume. When IV fluids are being administered, we know that careful monitoring is critical. The documentation every hour is essential for both the rate of the IV infusion as well as the total volume infused. For safety, infants should receive IV fluids in small volume bags, so 100 or 250 milliliter bags, to prevent accidental fluid overload should be used. So the IV site, of course, has to be assessed hourly for redness, edema, or signs of infiltration. Based on facility, primary continuous IV tubing is typically changed every 24 hours, but this, of course, can deviate. This is according to the standard pediatric safety practices as well. There are other important medication considerations. So loperamide or Imodium is not indicated for children with diarrhea and should be avoided. So for vomiting, the preferred antiemetic is Zofran or ondansetron because it's safe and effective in children as an antiemetic. Probiotics may be used to prevent or decrease the duration of antibiotic-associated diarrhea. And for infants with gastroesophageal reflux, management can include histamine 2 blockers. Also, this can be used for infants with gastric ulcers. And also for GERD, avoiding feedings just before bedtime can also help reduce any reflux symptoms. To discuss how to prevent fluid and electrolyte imbalances before dehydration develops, and also discuss how to prevent the spread of infection that causes it. So early intervention is necessary, and parents should be taught to begin ORT or oral rehydration therapy such as Pedialyte at the very first sign of any vomiting or diarrhea. So starting these fluids early can prevent progression to more severe dehydration. Other important topics are to avoid fruit juices or soda that are high in glucose, which can actually worsen diarrhea. So ORT is always the best choice. If parents believe that formula is not being tolerated by the infant, they should not change the formula alone. So any formula changes should be done only under the guidance of a provider. Sometimes switching formulas can worsen GI upset. Parents should also know when to call the clinic. So if the infant is not taking fluids well, medical guidance should be sought early. Prevention is a very important aspect of infection control. So if the infant is admitted in the hospital with gastroenteritis, contact precautions are required. Always implement standard precautions if it is not confirmed through lab tests yet, but once confirmed, the contact precautions should be implemented. Strict hand hygiene, of course, is essential both in the hospital and at home or in a clinic. So to prevent spread at home, caregivers should be taught proper hand hygiene and, of course, washing utensils and work surfaces like kitchen surfaces with hot soapy water. And if the infant has a sibling, of course, do not share any cups or sippy cups or any utensils or dishes. Finally, caregivers should be educated on the importance of the rotavirus vaccine, as mentioned before. So this will protect infants from the most common cause of severe gastroenteritis and dehydration. All of these combined strategies will help prevent both worsening dehydration and the infections that commonly cause it. Finally, let's apply the nursing process to everything we learned in this lecture. So we begin with the nursing diagnosis of diarrhea, which is a NANDA nursing diagnosis. So now we'll move on to assessment. We'll assess the amount, the color, the consistency, the time, and even the smell of the stools. We'll assess the overall hydration status. We'll look at the mental status, fontanelles, eyes, oral mucosa, skin turgor, heart rate, blood pressure, and the condition of the extremities. Our goals and interventions focus on preventing worsening dehydration. So in terms of implementation for an infant admitted with diarrhea, as we mentioned before, we'll follow standard precautions unless a confirmed diagnosis such as gastroenteritis is confirmed, then we'll implement contact precautions. Accurate intake and output is essential. This includes counting the wet diapers, the breastfeeding or formula feeding patterns in the presence of tears. Another important assessment for fluid status is daily weight. So weighing the infant daily on the same scale is one of the best indicators of changes in fluid volume. IV therapy may be required depending on the severity. We'll offer small, frequent amounts of oral rehydration solution for mild to moderate dehydration. A stool exam may also be necessary to determine the causes. We'll support the infant by allowing visits from the mother, hopefully minimizing other interactions if possible, such as younger siblings. This will possibly help reduce exposure. So we'll maintain skin integrity by changing diapers frequently and using barrier creams to prevent breakdown from loose stools. And again, parent education is critical, so parents must know to start ORT at the first sign of diarrhea or vomiting to prevent progression to severe dehydration. And of course, we talked about calling the clinic if the infant isn't taking PO intake well. So that should occur early. And again, we don't want to switch formula unless under the care of a provider, as this may worsen GI upset if done on their own. So this approach ensures we're assessing accurately, intervening early, and preventing complications from fluid and electrolyte imbalances.